Okay. Assalamu alaikum, sabah al-khair. Good morning, everybody. My name is Ibrahim Sbeih. I am a neurosurgeon talking to you from the Farah Healthcare Campus here in Amman, Jordan. And the topic for today will be about petroclival meningiomas. The theme, as usual, is to try to correlate the clinical picture with the radiology, with the operative findings, with the pathological specimens, try to put them together so that one can make sense of what we are dealing with. So I'm going to present this case of petroclival meningioma. Lots of people would be confused, and I was one of them before, about what constitutes a petroclival meningioma. This is petrous bone, which is part of the temporal bone, and this is the clivus. So the lesion has to be between the petrous and the clivus to be called petroclival lesion, and in this case, this is pathology specimen of petroclival meningioma. If one looks at the temporal bone, this is the internal determinatus where the 7th and 8th nerve goes through. Here is the jugular foramen where the 9th, 10th, 11th nerve goes through. This is the trigeminal going into the Meckel's cave. And then here in this spot is the 6th nerve. So to qualify to call a lesion a petroclival, it has to be medial to the internal determinatus. So it should not be here or here. It should be medial to the internal determinatus, between here and here, so to be called petroclival meningioma. So this is another look at it. This is the jugular foramen, glossopharyngeal vagus accessory going through jugular foramen, 7/8 facial vestibulocochlear going through the internal determinatus, trigeminal nerve going through Meckel's cave, and this is the 6th nerve going through the clivus. So the lesion has to be medial to here, so it should be in here, petroclival lesion. On MRI, this is the internal determinatus, so the lesion should be medial to it. If it is out, it is not a petroclival meningioma. People confuse this. They call it cerebellopontine angle. Anything in the posterior fossa is called cerebellopontine. Cerebellopontine has to be in this spot. So these lesions are not petroclival meningiomas. These are called outer petrous meningiomas. This is petrous bone and they are arising from the outer part of it, outer petrous meningioma. If you go in, more in, but still you have not reached the internal determinatus, this is still called outer middle petrous bone meningioma. If you are centered over the internal determinatus, you look like an acoustic in your room, but you are not. You are a meningioma which is centered over the internal determinatus. This is what is usually referred to as cerebellopontine angle meningioma. Like this one, or like this one. These are the true petroclival meningiomas. This is the internal determinatus, and the whole lesion is medial to it. So one has to be careful. In this case, most of the lesion is medial to it, so it's still petroclival meningioma, or this one, or this one. And then things go wild. Petroclival meningioma going to the middle fossa, to the cavernous sinus, to the supracellular area, to the orbit. So these lesions can be real complex. Up to 1970, these lesions were considered inoperable. Nobody would touch them. Nowadays, 85% can have an attempt at a radical excision. The year 1990 to 2000 was called the decade of the brain because there's so much developments that happened in that area. So our case for today is a petroclival meningioma. It's a female, 45-year-old from Iraq. And she presented with headaches and dizziness 1 year duration. That was some years back. And this was associated with numbness on the right side of her face, blurring of vision, unsteady gait, left-sided weakness. And then things progressed. For 5 months, she had double vision, and then her upper eyelid dropped down, constituting ptosis of her right upper eyelid. She was kept on steroids for 1 year. Why? Because she could not come to Jordan. Why? Because she was waiting for visa to enter Jordan. Why? Because she's living in Al-Anbar province. She could not go to Baghdad to get the visa. So she was put on steroids for a full year, high dose of steroids, which is nonsense. In her past history, medically, she's hypertensive. Surgically, she had 2 cesarean sections. Her vital signs were normal. Her general examination showed pale-looking lady, moon face because of the steroids. And you can see lots of hairs, hirsutism, and the steroid rash. General examination also showed umbilical hernia. The Glasgow Coma scale was 15/15. She had cerebellar signs, finger nose twisting, and this dyadococainesia was impaired, and she could not walk straight. She also showed a right third nerve palsy and the right sixth nerve palsy. This is the right eye. The sixth nerve palsy here, she could not look this way. And she had ptosis of her right eyelid. She could not look up. So third and sixth nerve pulses. But her pupils were intact. This is her facial nerve, showing it's good, but she had decreased sensation on the trigeminal nerve on the right side. She had left-sided weakness of grade 3/5 with increased tone. The same thing in her upper limb. So left-sided weakness, limb weakness. For, of course, privacy, we could not show her face, but she had a moon face. So this is to show you that she has a moon face, which is due to the steroids. Hemoglobin was 12.3, white PCs were high, and these were because of steroids. Anybody who's put on steroids for a long period of time, and this lady had this steroids for 1 year, would have this kind of reaction of white PCs. Bleeding profile was okay, blood sugar was high, and again, any patient on steroids for a long period of time would have diabetes, exaggerated or diabetes shown. Liver functions, kidney functions were okay, except chloride was 114. May I ask Marwan Furi, would that constitute any problem? Chloride 114. Marwan is our lab specialist. Images, and I'll go straight for the contrast enhancement lesion images. You can see this is the lesion. It is in between the petrous and the clivus. So this is representing a petroclival meningioma. And you can see it's going to the right cavernous sinus. So this is the only way to catch a sixth nerve and the third nerve in this area. So this is the lesion. Again, it goes down and then goes up, right up. This is the coronal. And you can say that the brainstem is compressed. This is the basilar artery here. So severe compression of her brainstem. This constitutes a threat to her life. Petroclival meningiomas can cause death because of the pressure on the brainstem. This is the sagittal, this is the edge of the clivus, this is normal clivus, and this is the tumor. You can see it's compressing the medulla, the pons, and the midbrain. MRA shows deviation. You can see basilar vertebra being pushed by the lesion on this side, on the right side. MRV to see, because we are going in this area, we need to know this is vein of Labey. This is very important for you. Again, this is what I used to always talk to you about. The technician who does not know what he is doing. The lesion is here, and some ignorant technician will just draw a line in his pen to, obscure this area. This is what we need to see. This is the lesion. So compare this with this. Technicians need supervision by our radiologists. We do the MRV because we are going here, and here we'll have lots of veins, and veins are as important as the arteries. Veins are usually forgotten, as if they don't exist, as if they are not important. If you damage a vein, it's just like damaging an artery. So you'll have a venous infarct as well as an arterial infarct. So you need to know the anatomy well, and you need to know the variations well of the superior petrosal vein, vein of Dandy, etc. So many papers written about the varieties of the venous drainage in that area. Also, many papers written about the varieties of the superior petrosal sinus in relation to the trigeminal nerve. Above it, below it, surrounding it. Again, you damage these, you would kill the patient. Again, here we're talking about this area, Petroclival area, and Petroclival area full of nerves here. So we need to know the veins, especially vein of Labbe. What's the differential diagnosis of the lesion that we have seen? We know we are presenting a case of petroclival meningiomas, but what would be the differential diagnosis? Again, this is not just a mental exercise. It is a true pathological, clinical sort of exercise. You have to think of this kind of pathology. What could it be? Because the approach is totally different. So this is petroclival meningioma. This is jugular foramen meningioma. This is epidermoid. The three commonest lesions in the cerebellum-montane angle lesion are the acoustic neuroma, meningiomas, and epidermoid. So these are different kinds of meningiomas, and these are all my cases. None of them is from outside. So this is facial nerve schwannoma. Rare, but it can happen. Schwannoma of the jugular foramen. This was a vagus nerve schwannoma, one of my cases. A lymphoma. In particular, this case was not mine, but I have several cases of lymphoma. Arachnoid cysts, DNET, desmo neuroectodermal tumor, epidermoid we have shown. Trigeminal schwannoma of different sizes. There are 4 grades of trigeminal schwannomas. Hemangioblastoma, a lipoma, a glomus jugulare tumor, so many things. If you go in for this tumor and you don't know it's a glomus, you would kill the patient and his family would kill you. So it's not just a mental exercise, it is preparing what you are going to do. Chondroma, chondrosarcoma, endolymphatic sac. Again, would one think of endolymphatic sac? Yes. I have 5 cases through my career of endolymphatic sac tumor presenting as a cerebellum-montane angle tumor. Neurosarcoidosis, metastasis. This was metastasis from melanoma, a choroid plexus, papilloma, etc. And somebody would come and say, I would treat this with gamma knife. It would be crime against humanity to treat this sarcoidosis with gamma knife. Medulloblastomas going to the laterally, atypical teratoid rhabdoid tumors, ependymoma, cholesterol granuloma presenting like this. Again, you want to know exactly what you are going to do with this case before you go in. Aneurysm, if you are not careful enough, you would have very bad surprise. And of course, clavis chordoma, which was mentioned before. So whenever you look at a lesion, you ask yourself, is this a meningioma? You have the differential diagnosis. And then you ask yourself, is this meningioma symptomatic? Because not every meningioma on the MRI needs to be attacked. Is this symptomatic? Mild headache in a critical situation like petroclival meningioma, you have to think twice. I had this case back in 1998. This young lady of 35 came to me with this petroclival meningioma, and she had mild trigeminal neuralgia. Slight pain, this was on the left side, slight pain in her trigeminal area. We gave her Tegretol, just 1 tablet of Tegretol, 200 milligram, and she responded well. So we left her. No change, 2001, 2002, 8, 12, 17. Look at this. 20 years, and there has been no change. Because we just wanted to wait, and this is the right thing to do.
Did it calcify or anything?
Sorry?
No calcification.
No, no. just a simple trigeminal neuralgia which responded to Tegretol. So we did a few consultations. Mr. Ibrahim Sadat, an ophthalmologist, will tell us about the findings here.
صباح الخير. So before we go into details, when we think about multiple or more than one cranial nerve lesion, we think of many things, and the question for us as a neuro-ophthalmologist is, where is the lesion rather than what is the lesion? So where is the lesion? To start with, before I go to anything else, I start thinking about something called myasthenia gravis, because if we don't think of this, we will forget it. Because we will do MRI, we will consult the neurosurgeon. So we don't think of myasthenia gravis, we will forget about it. So a very simple test in the clinic is to put ice on the ptosis. If it goes up, this is myasthenia most of the time. If it is not, we will go for something else. So we think of myasthenia, we think of the orbital apex, we think of the cavernous sinus, we think of a massive brain stem or brain stem vicinity lesion. So this was a bad tumor compressing of the visual apparatus or the visual system. The pupils were reactive or equally reactive because it was compressing probably equally. The vision is bad in both sides. Visual fields are decreased in sensitivity, both of them. Color vision was affected 1/17. Fundoscopy showed moderate optic disc swelling, bilateral papilledema, and there was horizontal more in the horizontal nystagmus more in the left eye. My question to Dr. Ibrahim, I did not see a cerebellar involvement. Why the?
There is.
There is because the cerebellum.
Yeah, finger nose testing, okay. And this diadochokinesia were affected.
Okay, all right. Any other slides?
That's right. Thank you.
Okay, so this was a composite and space-occupying lesion combined.
But just to show you, this is how ophthalmologists look at matters. Ptosis, he thinks of myasthenia gravis. Somebody else would say this is diabetic neuropathy of the third nerve. So each one of us think of it from his own side. That was the idea of this meeting, to listen to each other and see what do we think about the same problem with different eyes. We asked our cardiologist to see the patient, Dr. Hassan Al-Mas. ECG was normal. She is hypertensive on treatment. Clinical examination normal. She's a low risk for general anesthesia. But he asked that we postpone the surgery for 5 to 7 days because she was having Plavix. Another question, how many of our residents would check that the patient is actually not on anticoagulant or any of similar drugs? Aspirin. Aspirin would stop the surgery for me for 5 to 7 days. Plavix, heparin, etc. So you have to ask the patient, do not wait for the patient to tell you. You should go and ask him. Dr. Asad, we asked him to see because he also had some right-sided sensory neural hearing deterioration due to the lesion. Our anesthetist, Dr. Jamal Sharif, said the patient is fit for general anesthesia. But because we are putting her in the sitting position, there is high risk for air embolus. And with us here today, our anesthetist, Dr. Abu Aishi, where are you? So we've done so many cases of sitting position, and the risk is sitting position, is the sitting position to cause air embolism. So let's have a look at the anatomy of that area that we are going to operate upon. Anterior fossa, middle fossa, posterior fossa. Anterior fossa, middle fossa, we have the sphenoid wing. Middle fossa, posterior fossa, we have the petrous bone, the temporal bone petrous. So we are going to operate on this area. I better know my anatomy there. I always say it, and I keep saying it, we should not be graduating residents who do not know the anatomy. It's not just enough to do bare hole for subdural hematoma. Okay, we'll send you to the desert to treat people there, but you will not be a good neurosurgeon. Temporal bone is the key. This is the temporal bone, tenodotromeatus, etc. So anterior fossa, middle fossa, posterior fossa, the region is here. Anterior fossa, middle fossa, posterior fossa, this is a cadaver. We will be operating here. brainstem, cerebellum, cavernous sinus. This is the area we are going to operate. The clivus is divided in 3 parts. We draw a line between the interdictory meatus and the line between the jugular foramen. This is upper clivus, this is middle clivus, this is lower clivus. And remember, there is an angle here between the petrous and the clivus. It's not straight. And within this stretch of very few centimeters, 3 to 4 centimeters, you have everything. You have the brainstem, and then you have the lower cranial nerve, glossopharyngeal vagus accessory, 7/8 nerve, the abducent nerve, 6th nerve, and this is the trigeminal nerve. And here is the vein of Dandy or suberopetrosal vein going to the suberopetrosal sinus. We will be operating here. Brainstem has been removed. We are looking at both vertebral, basilar artery, pica, lower cranial nerves and the jugular foramen. Again, the 7th, 8th trigeminal, and the 6th nerve. 6th nerve is the longest nerve. It goes up, ascending for a long way. That's why it is the commonest nerve to be stretched, and it is called false neurological sign because it is stretched with anything. Again, will be here in this area. Same picture. You are in a dangerous area. It is full of mines. And if you are not careful, one of those mines will explode in your face and in the patient's face. Not only the arteries, but the veins, the suberopetrosal sinus, the inferior petrosal sinus going to jugular foramen. It's a very tricky area. This is the back of the clivus, upper clivus, middle clivus, 6th nerve, trigeminal nerve. Again, we're operating in here. And this area is very important. This is 6th nerve. I have to know the anatomy well. Trigeminal nerve dividing to V3, V2, V1. And this is 6th nerve going through something called the Dorello's canal underneath the Gruber's ligament. Again, if I don't know this piece of anatomy, I'll damage the patient. Who's Gruber? This is the Gruber ligament that we mentioned. Wenzel, Liebald. Gruber described this 1859. 1859, the Arab world was in a major sleep. Primo Dorello, Dorello's canal, again, Italian surgeon, described this canal 1905. We're still sleeping, the Arabs. The Gruber ligament, underneath it goes the abducent nerve. So we'll be operating in this very critical area. This is a close-up view, brainstem, petrous bone, we're here. Trigeminal ganglion, V3, V2, V1, and here is the 6th nerve. Now, in the Jordan exam board, neurosurgical board exam, I asked this anatomy, and some people say, well, the Swah is asking us a skull-based surgery. No, I'm asking anatomy. I'm not asking the candidate to tell me how he would remove the petroclival meningioma, but hell, he should know the anatomy in that area. Like a general surgeon should know the anatomy of the appendix. So again, petroclival meningioma is here. It should be medial to the interdictory meatus. If it is medial, then it will face the trigeminal, it will face the 6th nerve, and it will face the 3rd nerve. We got the consent for the surgery, detailed consent that we keep talking about. Delicate, fine information that we have to discuss with the patient. And we have to mention that it's going to be done in the sitting position. And the signature. This is what we do, sitting position. We are among very few centers around the world. Here in Farah Healthcare Campus, we do the sitting position. And this is unique in anesthesia. But when you master it as a surgeon and as an anesthetist, it is easy. People are just afraid of air embolism, and I say air embolism can happen anytime, even in the supine position. So patient is sitting, we put a table on top of the head so that the anesthetist can sneak and check his tubes, etc. And this is the arrangement, sitting for the patient, sitting for me. This is Dr. Mohammed Jallad, who is now a fully-fledged neurosurgeon from Australia. And we put the patient on monitoring. Sometimes we use navigation, etc. So it is a sophisticated, high tech. Patient is sitting. We will do this called lazy C incision. We'll remove the bone here, and then we'll go in. So I'll show you the video now. You have to mention that the patient is sitting, so you are looking at the back of her head. This is the right side, this is the left side. You are opening on the right side. So this is what appears this is the retractor taking the cerebellum, the right cerebellum to the midline. We will come across this, which is the facial nerve, and in front of it is the tumor. We'll go up, we'll see the third nerve. This is the dorsum celli. This is the third nerve. This is the posterior communicating, and this is the stalk of the pituitary going to the pituitary, dorsum celli. So from the sitting position, you can go right to the dorsum celli and see all this anatomy. So third nerve, pecum. This is the hypothalamus, infundibulum, and the stalk going to the pituitary. This is the trigeminal nerve. This is the facial nerve. The tumor is in between. This is facial nerve. These are the lower cranial nerve, glossopharyngeal vagus accessory. So you will work between the cranial nerves. And this is the facial nerve, lower cranial nerves.
What magnification is this?
12 to 15. Okay, so we'll show this on a video. As I said, the patient is sitting. This is the right side, this is midline. Cerebellum has been retracted to this side. And simply, we are walking between cranial nerves. The anatomical knowledge allows you to do this because you know each nerve where it lies. I here kept this part of the video to show you that there is a bleeding, but I'm not affected by it because the patient is in sitting position, so the blood just flows down by gravity. I am at the dorsum celli, and the origin of the tumor is there. So if I manage to separate the tumor from its origin, then I'll cut its blood supply. I just showed you the blood going down. Here's the third nerve, going to the cavernous sinus. Now I'm going underneath the third nerve. So third nerve and sixth nerve are structures that you will handle them. This is the trigeminal nerve, and underneath is the facial nerve, and this is the ICA, working between this and this. Here is some tissue there, and I know this is the sixth nerve. So this, what seems to be nothing, is the sixth nerve. But because I know the origin of the tumor, so I can tell where these are tracked. I use the ultrasonic aspirator, I read it piece by piece. Trigeminal, facial, I work in between. So here you are. Dorsum celli anatomy is very clear and preserved. This is sixth nerve, trigeminal nerve going to Michel's cave. Lower cranial nerves going to jugular frame. Histology, Dr. Fossa.
This case is interesting. It has some combined features of meningioma. You can see this is the typical meningothelial tab pattern, whirling patterns of spindle cells of meningioma with fibrous tissue in between. But this area, it has microcystic pattern. Part of the tumor is the microcystic pattern. You can see small, very small cystic areas of meningioma. Some of them are small capillary blood vessels, and this microcystic pattern. So this was meningioma, meningothelial with microcystic pattern. Epithelial membrane antigen is positive, and always I emphasize the pattern is very important. The positivity is usually membranous and usually is patchy. And this is very helpful to differentiate meningioma from other tumors. This is vimentin, epithelial membrane antigen and vimentin are positive in meningioma. In case we have other differentials, we want to confirm it. Key 7 was in this case about 2 to 3%, and this is within acceptable range of WHO grade 1 meningioma. So this is a meningioma, meningothelial with microcystic pattern.
So this is a meningioma grade 1, benign tumor. And if you remove it completely, like we did Simpson grade 1, the chances of it coming back is 5%. But if you go for partial excision, then the chances of recurrence is 100%. We removed it, we kept the patient intact. This is immediate postoperative MRI the very following day. And it shows that we have done a good job. We removed the tumor completely. And this is the patient, this is the incision. So back to the topic. This is just for the guys to wake up. Petroclival meningiomas between January 85 and January 2017. I had the pleasure of operating on 116 patients, which is a huge number really, simply because I became to be known as one who deals with such lesions, and people would just throw these cases at me and I would have them with pleasure. Now, as with any case, not all the patients would keep the follow-up. So 34 patients were lost for follow-up. I would not include them in the study. I have to have long follow-up. So 82 were kept for follow-up. But with those 82, there are short follow-ups and long follow-ups. I would not put the short follow-ups. I would love to put only the long follow-ups. So 54 had long follow-ups, and these are included in this study. 54 cases, each and every one of them. Because I used to be meticulous about documentation of my cases since I was a neurosurgical resident. I learned how to document my cases. So 54 patients, mostly females, lucky for us, males. And the one famous for these petroclival meningiomas is somebody called Takeshi Kawase. He is from Japan. He's a friend of mine. His wife, Miki, is a friend of my wife. And Takeshi Kawase, when he describes how he discovered the so-called Kawase approach, there's a surgery called by his name, Kawase approach. He said, I did not plan it. I got lost during surgery, and I did not want to do, so I drilled this one. I found myself in a good position. And it was called Kawase approach since then. So he classified these meningiomas into 4 types: the upper clivus, the cavernous, the tentorial, and the petroclival. And each one of them has different relations with the nerves. Look at this one. Third nerve here is different from third nerve here, different from third nerve here, different from third nerve here. So by studying the MRI, I would know where and exactly where to find each nerve. So this is the third nerve. For example, sixth nerve. Here is different from here, is different from here, is different from here, and so on and so forth. So this classification was very nice. So I classified my cases accordingly. The 54 cases, the upper clivus 20 cases, and this is example. So it is just lying in the upper part of the clivus. Upper clivus 20 cases. Cavernous type, which is just going from here into the cavernous sinus. It's called cavernous type. I have 15 cases. And the tentorial cases, which is just running across the tentorial, I have 12 cases. And the petroclival, which is the easiest, 7 cases. Easiest and 7 cases. I would wish I have more of these. So petroclival cases. The MRI, we studied the MRI of our cases. We found that we have a unilateral tumors, but also we have bilateral tumors. So again, seeing this, I suspected sarcoidosis, but it was negative. So it was a meningioma. Size, it could be small, it could be giant. And somebody would have the audacity and the courage, which I don't know how they get this audacity, courage, to stand up in meeting and say, I will treat this with gamma knife. This is absolute rubbish. Nobody would accept this. Yet some people would stand up and say, we treat this by hypofractionation. It does not apply. Yet people would stand up and say that. Shape could be anything. Look at this shape. We look at the plane of cleavage. This is a good one. There's a good plane of cleavage. This is a bad one. There's no plane of cleavage. This is extremely bad. Very hazy border. We look at the brainstem. Is there edema? If there is edema of the brainstem, this is a bad case. High complication rate. Look at the edema of the brainstem. We look at the origin of the clivus. Are we originating from the upper clivus or middle clivus or lower clivus or whole of the clivus? We look at the nodularity. The more nodularity there is, the bad they are. We look at the CT scan. We look at calcification and bone destruction. These are all our cases.
They're more irregular. The pathology is definitely more.
Yes, the more aggressive and the more difficult and the higher the complication rate. So when I sit with a patient, I would say we'll have 50% chances of complication or 20% chances. I have to be honest about it. 50%, and when the patient would ask, what kind of a complication? I would say death, hemiplegia, coma, whatever. I have to be honest with the patient about this because he is the one to go through it, not me. And we have to have a good venogram. This is our venograms. And look at this. It's detailed. You can see vena labae, you can see the cavernous sinus, you can see the superior petrosal sinus, you can see the inferior petrosal sinus. It's just not like another picture. It has to be detailed picture because we are going here and we need to know exactly the situation with the veins. As I say, a technician would come and draw the line and he would just obscure the pathology there. Sometimes we go for conventional angiogram, but sometimes we can actually embolize these cases if they are very vascular. Look at these beautiful pictures in our series. We look at the anatomy well, and we may, as I said, go for embolization if the tumor was very vascular. And this is one of the cases where we did the vascularization. This is tentorial artery coming from the cavernous portion of the cavernous sinus has been embolized to reduce the blood supply before surgery. Dr. Riyad Al-Adam is not here. He did the embolization. Sometimes Dr. Hazem Habour would do it, sometimes Dr. Adam, but in this case it was Dr. Adam. What was the presentation of my cases? They can present with anything because they are pressing on the brainstem. But the commonest presentation is this, abducent nerve. So much so, I can tell you this, any young patient, especially females, coming with a sixth nerve palsy, think of Petroclival meningiomas. Any young patient coming with decreased hearing, think of an acoustic neuroma. Don't go for wax in the ear and eye drops and LASIK surgery, etc., etc. This is the cause. This is the commonest presentation of the abduction. What would you do for the Petroclival meningioma surgery? Either total or subtotal with radiotherapy. So many approaches for this area. You can come from front, side, posterior. So there is something called anterior petrosal, which is the said Kawase. And now we call it Kawase triangle after the name of this Japanese neurosurgeon who discovered this by accident. Posterior petrosal, which is opening of the petrosal sinus and go to that angle. Or pre-sigmoid, sigmoid you go pre-sigmoid, sigmoid you go pre, and we have done a few of these cases. There is this video of this pre-sigmoid. It's okay, it's all right, we'll just move. erythrosigmoid, which is usual. This is the workhorse of this kind of lesions. And as said, we do it in the sitting position, under navigation, and under sort of follow-up of these cranial nerves observation. Again, for the sake of time, maybe I'll just show one video.
Did you do most of your cases in sitting position?
Yes.
These cases that you.
Yes. Not all of them, but most of them.
The majority.
Yeah. So just to show you that you are working between cranial nerves, facial, trigeminal, lower cranial nerves. This is sixth nerve. Just to show you at the end of surgery how satisfying it is. You have removed the tumor, you did not give your patient any radiation, and he's intact. No one would give radiation for a patient with his brain stem being compressed, because the radiation would need at least 1 year to give you a good result. And in this period, patient will be dead. Okay, I'll just move. Endoscopy has a new role, and I keep saying that in endoscopy lies the future of the neurosurgery. It's progressing, still so much shortcomings and so much obstacles to be overcome, especially CSF leak, but it's coming slowly. And I would think within 20, 30 years' time, endoscope will take over. So they can go through the nose into the petroclival like this. And look at the beautiful views you get with the endoscope. This is basilar artery, spinocerebellar artery, posterior artery, third nerve. Beautiful anatomy. The histological types of my cases: 15 transitional, 12 cyanomatous, 13 fibroids, 12 chordoid, two were pigmented like this, melanocytic. This was a case that was referred to me. We did the surgery, it was melanocytic. In 6 months' time, it flared up like this. It's very, very malignant. Melanocytic type of Petroclival meningiomas. Did I have morbidity? Of course. Going for these cases surgically, you have to accept some morbidity. Motor weakness, ataxia, infarct, edema, CSF leaks, and new cranial nerve deficits, because you are manipulating the cranial nerves. And the commonest nerve that is affected is, again, the adjacent nerve. Gross total resection in 38 out of 54 with recurrence of 5 cases. Near total resection, 9 out of 54 recurrence in 4 cases. Subtotal resection, 7 with recurrence of 4. And as I said, we have long follow-up. You have to have long follow-up to include your cases in a study. Surgical results were good in majority of cases, fair in 10, poor in 4. And I had mortality in 2 cases. These are formidable lesions. Patients can die. This is important to remember. So we have to be careful in what we tell the patients. Would we give radiotherapy? To me, this is a crime of the crimes. To give petroclival meningioma pressing the brainstem radiation. Not only that, radiation can cause cognitive function, visual deterioration, in case of pituitary panhypopituitarism, etc., and it can cause a new neoplasm. I'm not against radiation. I'm against radiation given in the wrong circumstances. Radiation is a good tool. It's adjuvant to treatment. We want it. We will use it, but not in the sense of using it for everything because I'm a mediocre surgeon and I cannot operate on these cases. Mediocre surgeons are in abundance. So within the period that we did primary surgery for 54, I treated with gamma knife 9 cases, and I treated with gamma knife cases that recurred after surgery. So gamma knife or radiation has a place to do, but not every case for radiation. This is what I'm against. This is abuse of the facility. 1996, this is me. How much? 22 years younger. Thinner, and more beautiful. This is the first patient I treated, coming back from Sweden, Stockholm, where I stayed for 6 months. I spent 6 months. I left my family, I left my children, I left my wife, I left my work to learn something new. And I brought it back. But there and then, I knew that a fool with a tool is still a fool. This is just a tool. like a suction, like microscope, like whatever. You just cannot use it for everything, otherwise you'll be fooled. I will show you some of the cases that I treated. So when I speak about gamma knife, I'm not coming from Mars or another planet. I am here in Jordan, and I have used, I was the first to use it. I was the one who did treatment for a majority of cases for gamma knife. But I have preservation about how it is abused. 2009 meningioma case, this is my name on the chart of the treatment. This 73-year-old female patient with atrial fibrillation. This is the indication of gamma knife. Deep-seated tumor that you cannot operate.
How many sessions?
One session. Yes, one session. Another case, 76, diabetic, hypertensive, blah, blah, blah. So I treated her with gamma knife. That's my name. So when I speak about gamma knife, I speak from the point of advantage, point of knowledge, point of power. I'm not speaking about it, just dismiss it. And these are the cases I have treated with gamma knife. So gamma knife is good, but please use it for those cases where you cannot operate. They have come with a new indication, the mediocre surgeons. They would say, patient refuse surgery, and we have to abide by the patient's wish. If you are my patient and you come to me with a Petroclival meningioma like this, and I tell you, listen, I will do surgery for you, but surgery carries risk about 20-30% of death, hemiplegia, etc., etc. Or I would give you radiation. I would give you in the morning, you are home. In the afternoon, no surgery, no anesthesia. What would you choose? You choose gamma knife. It is the way you present it to the patient. But they don't tell the patient that radiation is going to take 2 years to achieve. And to keep that brainstem under pressure for 2 years is a crime.
Usually it's for treat افتح راسك والأشعة.
بالضبط. افتح راسك والأشعة فيش فيها جراحة. So radiosurgery has its limitation. I would just refer you to Lars Laxell. Lars Laxell is the Swedish neurosurgeon who invented the gamma knife. Back in 68, 70, that he started thinking about it. He said, it's a delivery of high dose of radiation. High dose of radiation. And the whole dose of radiation given in one session. 15 grays or 20 grays in one session. So it's a high dose of radiation given to a small volume of tumor, which is critically deeply situated that you cannot operate upon. Look at this roadmap that Lars Laxell gave us. Small tumors that you cannot operate and are away from the optic apparatus. Now we treat 7 centimeters tumors. We treat 70 metastases. We treat everything. So it is abuse of the system. So limitations are there. Radiosurgery is good. But again, I call it radiotherapy, stereotactic radiotherapy, and not radiosurgery, because there is no surgery. Can it cause malignancy? Yes, it can. And these are the cases of malignancy after gamma knife. I collected it from the literature, and I added 2 of my cases. This was sent for publication, and the people of the gamma knife stopped the publication because they don't want anybody to hear about this.
The mechanism being the actual radiation.
Actual radiation, just radiation. You see, the word radiosurgery is fancy. Radiosurgery, there's no surgery in it. Gamma knife, gamma which work like a knife, it's nonsense. It's radiation. It's good when it is properly given. One of my cases, this is my name, this is the treatment date, 97, and this is this female, 17-year-old. This is neurofibromatosis type 2, bilateral acoustic neuroma, bilateral cavernous meningioma, cortical meningioma. So we went for this, which is the largest tumor on the left side, and gave it gamma radiation. She disappeared. Came back with this. This is a tumor that developed on the top of this tumor. So giving radiation to this tumor, we give it in isodoses, like this lines. This tumor actually developed along the lines of the isodose. And this was a malignant meningioma. Malignant meningioma on top of radiated acoustic neuroma. histologically proven.
Was it a case highly selected for gamma, properly selected?
Yes, it's an F2, and exactly the indication were okay. But here, when she came with this, the only way is to go and excise it completely. And from excision, we got the histology as a malignant meningioma. Another case, a 15-year-old male patient, back in '97. This is me. So I know about the machinations of gamma knife. Bilateral acoustic, bilateral cavernous, cortical meningiomas, and schwannoma of the accessory nerve there. So we give this gamma knife. Again, he disappeared and came back with this. His meningioma of the cavernous sinus tends to be malignant. We excised it, and it is malignant. So I'm not against gamma radiation. I'm against the abuse of the gamma radiation.
So why did you go for it surgically initially? Why did you?
This one.
Yeah.
Which one do you go for?
This one.
We went surgically for this because he presented with quadriparesis, and then he presented with sickener palsy here. So cavernous, true cavernous meningiomas, you cannot excise surgically. That's why it's a good indication for gamma radiation. A proton beam, proton stereotactic surgery is used nowadays for this treatment. Illustrative cases of these Petroclival meningiomas. This is before and after surgery. 53-year-old patient with this tumor that has been removed and followed up. This is the histology. So all these cases are ours. They are well documented. They are histologically verified. 52-year-old male patient with this female patient, yes. And this is the post-op. Again, this is called upper clivus cavernous type. This is very massive tumor. And this, massive. This case was referred to us, I think, from Iraq for gamma knife. Somebody in Iraq, a neurosurgeon, thought this is good for gamma knife. You know why? Because he cannot operate. So instead of saying, I cannot operate, he would say, go to Jordan for gamma knife. We don't have it here. Of course you can't. There's no brainstem left, so you have to go for surgery. This before and after histology confirmed. This Sudanese lady. And this, which I described earlier as a very difficult case. Nodular, it is inside the brain. This is a brainstem. It is inside the brainstem. Nodular brain edema, everything in it says, don't touch me. And this case was a Jordanian from Palestinian origin, came to me begging for surgery. And I tried actually not to. I was clever. Said, this is difficult case, high rate of complication. This is one that carries lots of complications. So thank you very much. Said, no, we will accept surgery, whatever. And lots of people interfered and phoned me. So I really went to theater and I was shivering, knowing that how much difficult that is. It was extremely difficult. That's before surgery, and this is after surgery. She came up with some weakness in her arm, but it was meningioma grade 1. Having seen her after surgery, I was pleased. But during surgery, I was petrified. And this is 2 months. Beautiful. No recurrence whatsoever. Followed her up for 5 years. There's a small thing there, which we are keeping an eye. It's been another 3 years and did not change, and she's well, so we did nothing.
Grade 1, you know, there's no keyboard, there's nothing.
No, this is the idea. Another case, before and after surgery. Another case from Syria with this large tumor before and after surgery and long follow-up. This patient had surgery at St. Elsewhere. Somebody went in there. What did they do? They removed the cerebellum. Because he has no idea. And instead of saying, I can't do this case, He went in, he just removed the cerebellum, and the tumor is the same. Now, he told the patient, we have removed most of the tumor, there's some tumor left, and we'll send you to Jordan for gamma radiation. Isn't this a crime? Of course, this is not a case for any radiation, this is a case for surgery. We went in for surgery, although it is a redo, we removed it completely, it's a grade 1. So in conclusion, petroclival meningiomas are formidable lesions to treat. بالعربي formidable يعني نيلة. نيلة متنيلة بنيلة حسب الرأي المصري. Factors that affect the outcome of surgery and recurrence include adherence to the neurovascular structures, bony invasion, multiple fossa involvement, previous surgery, among other factors. It is difficult, formidable lesion to treat. And to me, retrosigmoid approach is still, in semi-sitting position, is an excellent approach to deal with the petroclival meningiomas. However, I have used the other approaches, the petrosal, the pre-sigmoid, the others, because every case has its own specific needs for surgery. But most important thing is the anatomical knowledge. With this, I finish, and the floor is open for discussion. Please.
Morning. Just to give the oncology perspective on this, and Dr. Khouri's question is a great introduction to that. There's nothing benign about a benign brain lesion, and in this case, meningothelial meningioma grade 1, it's quote-unquote a benign lesion. If not dealt with properly, would have simply led to the demise of this patient with horrible morbidity, mortality in the interim. And to sum up a very lengthy, complicated, convoluted body of literature, hormonal therapy does not work, chemotherapy does not work, biological therapy does not work, immunological therapy does not work.
Dr. Adnan Rajab the other day asked you about hormonal treatment for meningioma. Can you comment on this?
The bottom line, it does not work. Yani there's a lot of data about the role of tamoxifen in meningiomas, given the fact that PR, progesterone receptor positivity, etc., and even in the avidly progesterone receptor subsets. Bottom line, it does not work. If these patients don't have proper surgical intervention at the get-go, they're really doomed for a miserable course of recurrence. Now, one thing that I'm really concerned about is when these patients get radiotherapy, initially, instead of surgery, because of the assumption that they have meningiomas, look at what they potentially can miss. All of these are meningiomas. And is this thing working? I will do. All of these are meningiomas, but this could have been all sorts of different things, including arachnoid stop, DNATs, which would really be sensitive to chemotherapy after the surgery, epidermoids, arachnoid cysts, schwannomas. Thank you. Oh, that's much better. Schwannomas, jugular foramen schwannomas, with severe different implications to the management. Trigeminal schwannomas, lipomas, hemangioblastomas, these are not going to necessarily change the pattern of treatment because the mainstay of all of this is surgical. However, you can still get sarcoid that would look exactly like this, and this is not even benign malignant, this is not a malignancy, and it can easily be missed, and patients would die because of neurosarcoidosis that would initially improve to radiotherapy, and were still initially improved to radiosurgery. Ependymomas can present like this, and the implications for that is the chemotherapy choices you're going to use post-operatively. Medulloblastomas can have similar presentations, and again the implications for that is, and for ependymomas, is platinum-based chemotherapy post-operatively and on post-radiotherapy in an adjuvant setting. These have tremendous implications. Now, I cannot emphasize enough the fact that these can be metastases, and without really looking carefully in the history and physical in these patients, you're going to miss the primary. And you could have spared this patient a huge surgery had you detected the primary person. The classic example is the lady with a brain lesion whose breasts have never been examined, and she has brain cancer, breast cancer. And please don't forget that these patients can have lymphomas, and primary CNS lymphomas can present in a periclival pattern. And I've seen those. They are extremely rare in this area, particularly around the clivus. But the implications are tremendous. If these are lymphomas, it's either secondary from lymphoma elsewhere or primary CNS lymphoma, where had this patient been subjected to radiotherapy initially, this would have improved and the patient would have succumbed to her disease that could have been really controlled with high-dose methotrexate for a very long time, even sparing her radiotherapy, not alone surgery. These are actual cases. These are not hypothetical cases about what could masquerade as a petroclival meningioma. These are actual cases that had a very similar clinical and radiological presentation.
Okay. Any questions, any comments? Please, Dr. Nasser, سمع العيش.
مرة ثانية أقول شكرا لك. أنت تشاطبنا بعضا من نبوع علمك وعظيم الخبرات. أتمنى لو نضع لك حرزة زرقاء مع أني لا أعتقد بها. أنت ذخيرة بها.
شكرا جزيلا. Thank you. Please.
بالنسبة للclavics you were talking about discussing them last week. There's some talk about clavics is not really an issue.
بس عشان الأودينس I'm talking about anticoagulants drugs like aspirin.
Aspirin, I agree with. But Plavix, there's a lot of comments nowadays as to whether you really need to stop Plavix as far as surgery is concerned. I don't know what your comments are about that. There's a lot of talk, especially in England. You know, the Europeans say that it's okay to go to surgery even though the patient is on Plavix. I don't know what I'm not a surgeon. I just would like your opinion on that.
I am an old dog, and it's difficult to teach old dog a new trick. I've been taught all my life that these cases better wait for 5 to 7 days. And I know this literature coming up that it doesn't matter, go ahead. But I would not dare
only
to.
For Plavix, not so much
yes,
for aspirin.
absolutely.
I agree with you for aspirin, but words
I
are
agree.
different. Plavix it's also an antiplatelet, but it's not a coax tool as aspirin.
I would not dare to do that, especially if there is an elective case. There's no point on going into a dangerous area. Nothing may not happen. Nothing can happen, but still, I cannot dare to do that, especially in an elective case like petroclival meningioma. So I just wait. Maybe the literature is correct, but I cannot dare to do that.
As a hematologist, not as an oncologist, I have to emphasize the fact that Plavix, Petroclival would impair irreversibly the platelet function, and you won't get near normal platelet function before 7 to 10 days after stopping them. Now, it really depends upon why you're giving the Plavix. Is this a patient who had an MI 1 month earlier or 3 weeks earlier and had a stent, etc., where the indication for Plavix is very different than somebody whose coronary intervention was more than 6 months earlier. So it's a case-by-case thing where you weigh the risks of benefits on the intervention that has been made. Can I get away with holding the Plavix for a while? Usually, in elective cases, in cold cases, for somebody whose coronary intervention has been more than 6 months ago, you're quite safe after a lengthy discussion with the neurosurgeon and the cardiologist, which we truly do, to actually hold for 7 to 10 days before. Sometimes, if you read things urgently, you can actually give a surge of platelets at the time of surgery without actually holding the Plavix before or after, just to maintain hemostasis at the actual time of the incision. However, I have to emphasize that this is individualized case by case, and these are lengthy discussions between the neurosurgeon, hematologist, and the cardiologist.
You just vote for the residents in the hall. Please go and ask the patient about antiplatelets, aspirins, etc. Don't wait the patient to volunteer to tell you. Most patients would not. he would say aspirin. It's not a drug. It's this. He would not even think about it. I'll just tell you about this one case I knew about. A neurosurgeon, a friend of mine, had a carpal tunnel. Simple carpal tunnel. He went to a colleague, a neurosurgeon, who admitted him, and nobody bothered to ask what he is taking. And he ended with a huge hematoma after the carpal tunnel. He was off work for 1 year. Simple carpal tunnel. Nobody asked about aspirin. So it's very important. Dr. Adnan, you have views about the Dr. Adnan Abu Rajab?
Yes.
You have your views about the hormonal treatment of meningioma?
Well, it is not, I never used it.
I know.
But I said last time I read about it, that they are trying the hormonal treatment and the tyrosine kinase inhibitors. But this is first trial.
Sure. So somebody is trying to give hormonal treatment. Okay, with no more questions, I thank you. We'll meet out. There is one question, Dr. Atan, please.
Did you have any case of condosis?
Yes, yes, I do. I had 3 cases. Yes.
And was this pre-operative or not?
Pre-operative, I knew what it was. Thank you. We'll meet next Wednesday. Thank you.